I'd like to introduce formally Dr. Dirk Dressler. I'd like to introduce you formally. You are the Movement Disorders Section, Department of Neurology from Hanover in Germany. And we're going to listen to you talking about stress-induced idiopathic dystonia. So just to translate that a little bit into layman's terms, and please again correct me if I'm misrepresenting it, but idiopathic meaning arising spontaneously and of no known or obvious cause. So a dystonia that arises spontaneously. And over to you, Dr. Dressler.
Yeah, good afternoon. I'm Professor Dressler. I'm the Professor of Neurology and Movement Disorders at Hanover Medical School, and I'm running, obviously, the Movement Disorder Group in Hanover. I'm currently in Kyoto, and technically, I hope everything works out. We had a bit of a problem to connect with my laptop, so I'm running the show now from my iPhone. Can I see my slides when you present them, or? At the moment, I only see myself, which is nice, but not good
yes,
enough.
I will open it, Dr. Dressler.
Okay, so I need to see my slides to work with them.
Yeah, don't worry.
Okay, yeah. So the topic for my presentation, I think, is an important one because ever since we focused on dystonias, the question was, what is the relationship of this condition to the psychology of our patients? And so we had been following this for basically the last 40 years. And only just very recently, we were the first actually worldwide who could produce solid scientific data on this issue. So can I have the first slide, please?
You should see it. Yeah. Is it this one?
Yeah, but I don't see it.
Ah.
What do I have to do to see my slides?
On the smartphone, I'm not sure. You should have buttons somewhere.
Does this one on?
No.
What share do you see the slide on the
No,
computer screen?
No, I just see Edwid's the title slide.
I see it. I don't see myself anymore, but I see my slides.
Oh,
Okay.
okay, great.
So press the next one, please.
Okay.
Okay, the next one, please. So the background of the study we have been performing, and which I will be sharing with you, is there are obviously many forms of dystonia, and the most common form is cervical dystonia, and within cervical dystonia, this idiopathic form is the classic normal form how dystonia presents, and as you rightly said, that means that it's not a drug-induced one, it's not a psychogenic one, it's not a traumatic one or anything. It is the normal, most common form of cervical dystonia. And with this, no, go back with the slide, sorry. Stay with the second slide. And so with this is the most common form of dystonia, and that was important. We wanted to do our study on a study population which represents the majority of the dystonia patients. And so the issue was the stress as a etiological factor, as a factor to provoke and to trigger of dystonia has, as I said before, long been discussed. However, the problem was we could, and anybody else could only draw to anecdotal reports. So colleagues said, yeah, we had a patient, and I remember a patient years ago, and I heard from a colleague that there was another patient. So that is obviously not good enough to really go into scientific details to describe this issue and this patient population. Can you move to the second slide? Next slide. I have to mention a caveat. Go back, please. I have to mention a caveat. We are not talking about the issue of psychogenic or functional dystonia. So we talk about idiopathic dystonia and how that can be triggered by stress. Functional dystonia, that's a completely different issue. It's nicely described, not necessarily always very easy to diagnose, but functional dystonia is a completely different presentation of dystonia. We call it dystonia. People before have said it is not dystonia, it's functional, it's psychogenic. So this presentation is not about functional psychogenic dystonia. It is about the most common form of dystonia, and again, how stress can trigger the offset of this condition. Next slide, please. So the results I'm presenting here with you have just recently been published earlier this year under the same title as my presentation here, so everybody can read it up in the internet. Next slide, please. Next slide. What have been the methods we have been applying to generate our scientific data? So the overall design of the study was a non-interventional descriptive study. So those are some scientific details. Maybe the patients amongst us are not necessarily interested in this. You can call it a collection of case series of individual cases. It was mixed prospective, mixed retrospective in design. So most of the data were gathered in the process of following up the patients. Some data had to be generated by going into the archives, and the nice thing with the database is that the patients reported here have been under very close scrutiny in the course of regular appointments in a continued form of botulinum toxin therapy. So basically, when we talk about the cause of the disease, we had direct access to the patients. We saw them every 3 months, and that generated very valuable scientific data. Semi-structured interviews we used to fill up the gaps in between. And so this particular study was part of a very large study we actually also finished and published earlier this year on the natural cause of idiopathic cervical dystonia. Next slide, please. So inclusion criteria, just to follow the usual scientific approach. Again, idiopathic cervical dystonia, not patients with other dystonic conditions. We had to be able to follow the patients for at least 2 years. And all of these patients had excessive psychological stress. So that was defined as the worst stress ever before or after the onset of idiopathic cervical dystonia. And that stress, to be more precise with interactions between stress and cervical dystonia, had to occur within a time limit of 6 months. So stress that happened years ago and did not provoke dystonia, and only years later dystonia started, was not considered in the study. Exclusion criteria, again, not psychogenic functional cervical dystonia, not symptomatic dystonia, so no tardive dystonias, and also non-dystonic torticollis was explicitly excluded in this study. Next slide, please. Those here are don't go to into the small print. Those were all the factors, the parameters of the study we were collecting. So epidemiological data, sex and age of the patient, duration of their condition, and then to describe the cause of the disease after onset, we made various definitions and generated particular data on that. Next slide, please. So obviously part of the study was to describe how that cervical dystonia related to excessive psychological stress carried on after its onset. Those is a schematic view, what phases we can identify, we can separate, and we collected for each of the patients involved. So we had a plateau phase, an onset phase, plateau phase, remission phase, if it occurs, and then we had this overall observation period. Sorry, there are mistakes on the slides I see here, but that's obviously due to you're running a different PowerPoint version. So sorry but it's not important what's missing on the slide in the left corner. Next slide, please. So what were the results? The results, next slide, please. They were as such. Altogether, we could collect 13 patients with stress and related idiopathic cervical dystonia. Age at onset was around 39 years. The female to male ratio was on the side of females. We can discuss this because the previous presenter mentioned this. In our large epidemiological study, it's a very robust finding that all forms of dystonia have a strong, very strong female preference and preponderance. And so the observation period was in the order of 8 years. Next slide, please. This is a little overview over what exactly the patients considered as an excessive psychological stress. We can't go through all the different patients with their very personal stressful situations, but it's obviously when you read this, you can understand that stress is excessive, especially as in most cases various stresses coincided at a small period of time. So just here you have you have criminal charges, you have migration, you have familiar problems, you have violent crimes, you have all these kind of things. So really terrible things where it's easy for us to understand that they generate this excessive psychological stress. Next slide, please. Okay, so the most important thing got lost with your PowerPoint slide. So this is really very bad. I see it here. Yeah, that's really bad. You see, okay, yeah. So I switched to the other mode. What you can see here is that all these patients collected have a very rapid onset of their course, and that is absolutely different from the normal cause of cervical dystonia, where you have usually an onset phase of 3 to 5 years. Here, if you have this excessive stress, your cervical dystonia starts within a few weeks. That is really the ascending part of all of these curves you can see here is really extremely steep and much different really from the natural course in idiopathic cervical dystonia not related to stress. And you see a second thing here in the slide, with the exception of two atypical cases, all patients have a reduction of their cervical dystonia starting relatively early after a few months, 1 or 2 years, and you see that this improvement is robust. It never completely goes away, the cervical dystonia in these patients, but it gets much better. And again, this is a feature you do not see when stress is not the triggering factor. Next slide, please. You see here a superimposition of the individual causes, and you see again what I said before. You have a very rapid onset, and you have a robust improvement after a relatively short period of time. So can I have the next slide, please? This is again a little bit of a numerical evaluation of the graph you saw before. Next slide, please. And this is, we are running out of time. This is the summary of what I tried to share with you this afternoon. This is the first description that excessive psychological stress can trigger off idiopathic cervical dystonia. The subsequent cervical dystonia is typical in its clinical features and presentation, but the cause it follows is very different from the cervical dystonias not preceded by excessive stress. Rapid onset, rapid and robust high remission. You have to press the button again. Okay, thank you. And what you could also see here in our data, there was a very close temporal relationship between the stress and the onset of cervical dystonia. And so our conclusion is that excessive psychological stress is one of the many epigenetic factors triggering off idiopathic cervical dystonia or idiopathic dystonia. The possible mechanisms how stress can, trigger off this organic disease is largely unclear. There are hypotheses. I don't want to go into details here in this context. What we can learn from our data is that there are obviously interactions between stress and dystonia. We know, and previous presenter also mentioned that, we know that stress can modulate on a daily basis, basically, the presentation of dystonia. Stress can also play a role in functional psychogenic dystonia, so psychotrauma and these kind of things. And with our data, we have to broaden up the spectrum of interactions between stress and dystonia by hypothesizing that epigenetic stress can be an epigenetic factor. Open questions are you have to keep on pressing the buttons. Okay, the last one. Open questions, as always, are existing. We don't know whether what we have been describing in these kind of cervical dystonia is also true maybe for spasmodic dysphonia, maybe true for blepharospasm. Another important question would be, what we have been describing was massive, excessive stress. What is the role of mild stress as a trigger factor? Can that also be a factor triggering it off? Very difficult to design a study to find this, because what is mild stress? A last thing is I want to mention there have been some historical discussions about war trauma-induced movement disorders. With our data, we would try to reevaluate these cases and suggest that they were not cases of psychogenic movement disorders or functional movement disorders, but rather some of them might be what we have been describing here with our patients, triggered stress, triggered idiopathic dystonia. And with this, I hope I could have stayed roughly in time and would like to finish my presentations. And please come up with questions.
Thank you so much, Professor Dressler. And we do have a couple of questions. In your initial study, how many patients took part?
The original study on the natural cause of cervical dystonia included 100 patients.
Okay.
And out of these 100 patients, we identified these 13 or 15 patients presented today. So we were actually surprised that this subpopulation I presented today had this high frequency of 15%, because in the anecdotal reports there were singular patients mentioned. You know, I had a patient 10 years ago, I had a patient 20 years ago, so that was the kind of data we had. But when you go into larger patient groups, you see that it's 15% of patients with these features. We were surprised about this.
Okay. And you showed in the data that the dystonia resolved naturally.
Yeah.
Was that when the trigger was removed, or did that resolve anyway?
Yes. That is what we believe. These excessive stresses, they last very long. You know, they are massive, but usually after half a year or after a year, they start to settle down. And pretty much in parallel to this, we saw that also the dystonia resolved. And again, that is something what you do not see in dystonia not triggered by stress. So stress can very rapidly and very robustly trigger the onset, but at the same time, when that stress resolves, that's our hypothesis, dystonia can get better.
Okay.
What we saw, and I did not describe in this presentation, the extent of dystonia triggered was usually stronger than what you see initially in other patients. So altogether, it was for the patients usually a traumatic situation, but with the knowledge we gathered, we could actually advise them and predict. Also, it looks very traumatic, rapid onset, strong dystonia, lots of dystonia in a short period of time. We said, you are lucky because we believe that you belong to that small subgroup where dystonia can actually get better.
Okay. And did they need treatment after resolution?
No, there were very few patients who had a complete stop of their symptomatology. Of course, that would not require any further treatment, but all patients who had remaining symptoms, they entered treatment, and they received the symptomatic treatment in the form of botulinum toxin therapy.
Okay, and I have one final question, kind of related. So, have you seen this stress-related dystonia following a physical injury? So I guess two things: physical injury to the area, but also a physical injury that produced a stress response.
That's a complicated question, actually. You know, we know that non-idiopathic dystonia can be triggered off by trauma to the nervous system, peripherally or centrally. So if you have a peripheral injury in your arm, you can develop a post-traumatic dystonia. If you have central nervous system injury, affecting usually your basal ganglia, you can have symptomatic dystonia. That is trauma related dystonia in general. If that mechanical trauma also produces psychological traumatization, excessive stress, for example, that could add up, but that is not what we had been examining here, because we explicitly excluded symptomatic forms of dystonia.
Thank you so much, Professor Dressler. Again, another fascinating
Thank you, Dr.
presentation.
Dressler.
And thank you so much for doing that from your iPhone as well. In what knows time difference, I don't know, but thank you so much.
7 hours time difference here in
7
Kyoto.
hours time difference. I don't even know.
Thank you.